All right, everyone, I've got 1:01 p.m. Central Time. So we are going to go ahead and get started. Also, don't be shy. I'd love to see everyone's face. It's another day, another webinar. So anytime we get an opportunity to see some faces, it's always nice. So welcome to Dental Therapy, the Basics. This is webinar 1 of 3 in our series. So I know there's lots of webinars out there, so thank you for choosing us and thank you for your interest in this topic. So this webinar is brought to you and being funded and supported by the National Indian Health Board, Tribal Oral Health Initiative through the Tribes and Tribal Organization Education and Outreach Programs for Dental Health Aid Therapy. And for those of you that are not familiar with the Southern Plains Tribal Health Board, Oklahoma Tribal Epidemiology Center, the Southern Plains Tribal Health Board is a nonprofit tribal public health organization that was established in 1972 to provide a unified voice on tribal public health needs and policy for the 44 federally recognized tribes that are located in the states of Oklahoma, Kansas, and Texas. The Southern Plains Tribal Health Board serves as a liaison between the National Indian Health Board, which works closely with Congress and Senate on Indian health policy for Indian country, and the 44 tribes here in Oklahoma, Kansas, and Texas. Our role is to improve tribal public health outcomes for American Indians through partnerships, advocacy, education, data, research, and training. The Oklahoma Area Tribal Epidemiology Center is a division under the Southern Plains Tribal Health Board, and the OKTEC, as we call it, is one of 12 TECs located across the United States, and they were established in 2005 through core funding that was received from the Indian Health Service. What we do chronic disease prevention, health promotion, survey design and implementation, program evaluation, cultural competency trainings, data analysis, geographic information systems, and grant writing resources, and we provide that to our tribes and tribal organizations. The Oklahoma TEC also assists with American Indian, Alaska Native health systems and programs by improving access to the highest quality, American Indian, Alaskan Native health data available. The Native Oral Health Network is a program that's supported by the CDC and the Oklahoma Shared Clinical and Translational Resources Program. And that program is from the University of Oklahoma Health Sciences Center. And this program is housed here at Southern Plains Tribal Health Board. Known as what we call it for short, known as a group of oral and public health professionals that really center and group around the fact that oral health is a vital part of overall health and wellness, and we collaborate to improve the oral health of our Native communities through sharing resources, peer support, and community engagement. So your facilitators for today, you're stuck with me, the one that really internet is apparently not super reliable, so hopefully we'll do better in the remainder of this webinar. I'm the Oral Health Programs Manager from the Southern Plains Tribal Health Board. I'm also a member of the Cherokee Nation. And with me today is Alexandria Holt. She works with me on known programs and activities. She's a public health specialist, also from the Southern Plains Tribal Health Board. I am so excited for our speakers today. We've got Thera Bianchi. She is the program director over the oral health access campaigns at Community Catalyst. We also have Brett Weber. He's the public health policy and programs manager at the National Indian Health Board, and he heads up the Tribal Oral Health Initiative. So we've got some great information for you guys today. So I'm glad we have our speakers and all of you here to hear it. Okay, so a few housekeeping things. All the attendees are muted. If you're not muted, please make sure you do that. Also, say hi to everyone in the chat box. We've got people from all over. So if you put your name and organization, where you're from and where you're representing in the chat box, that would be fantastic. Also, this webinar is being recorded. And my phone is not on silent either. Questions will be facilitated through the chat box at the end of the webinar. Alex is going to help with that. Information to obtain the 1.5 hours of continuing dental education credits that are given, that will be given out at the end of the webinar. And if there are any technical difficulties, you can message Alex Holt directly into the chat box, or her email is listed here, which is also an option. Okay, so course objectives. What do we want to accomplish today? Well, the objective for today's webinar is that we all have a shared understanding of the definition of dental therapy. We'll also have an understanding of the various state and tribal approaches compared to national standards. The impetus in creating national partnership, the National Partnership for Dental Therapy, the impact of dental therapy in improving oral health outcomes, and the purpose and efforts of the National Indian Health Board's Tribal Oral Health Initiative. Okay, so before we jump in, I just want to give a brief update on some activities and projects through the Native Oral Health Network. Our mission is building healthier Native communities by connecting oral health to overall health and wellness through peer support, collaboration, and community engagement, like I mentioned earlier. Since this group was formally put together, I guess in 2017, mid 2017. Since then, we now have over 120 members that are represented in 8 states. Of those members, they bring 31 unique areas of expertise and diversity to our group, and they are represented by these organizations. So we have Indian Health Service, tribes, urban Indian clinics, TECs are represented, and not just ours, but others across the nation, also government agencies, nonprofit and academic organizations, and professional associations. Some of our current projects that we're working on right now, we have been able to increase our primary oral health data collection through our tribal births survey. So this 40-question survey now consists of 7 oral health questions, which is up from 2 that we had in previous versions. So we're really excited about that. And we've been working the majority of this year, I would say maybe since February, on our peer-reviewed publication, which is called Oral Health Among Indian Health Service Oklahoma City Area Population, a review of the current data. This report highlights the most current oral health data from the 3 oral health GIPRA measures, which is access to dental care, dental sealants, and fluoride. And we also look at all of the IHS oral health surveys per age cohort, among other oral health indicators. So be on the lookout for this, hopefully sometime next month. Also, we are going to be presenting alongside the Great Lakes Intertribal Epidemiology Center at the American Public Health Association conference, their annual conference next week. So we're really excited about that. We're going to be talking about going into a little bit more detail about the Native Oral Health Network, how we kind of came to be, and how some of these cross-agency collaborations are really improving oral health outcomes, and how we're able to reach more areas, more communities, and be able to create more resources, and with less resources, create more with less. So the other thing that we're working on, Alex, like I mentioned earlier, Alex Holt, that works with us on the Native Oral Health Network, she is finishing up her MPH, and so she'll have her practicum project to share with us in the group, which is listed there, and also the Dental Health Aid Therapy Education and Outreach, which is this webinar series is part of that outreach. So save the dates for December 3rd and January 14th, which will be webinars 2 and 3 in this series. Okay, so just to set the stage for our presenters and attendees here, and especially those that are really not familiar too much with kind of the oral health landscape in Oklahoma, I wanted to give a brief, really high-level overview of oral health, kind of oral health status in Oklahoma. So the oral health care delivery system in Oklahoma, as it is in many other states, needs improvement. Oklahoma has a 60% critical shortage of dentists, with 65 of Oklahoma's 77 counties federally designated as health provider shortage areas for dental service. And as many of you know, dental school is expensive. We have dental students that are graduating with hundreds of thousands of dollars in student loan debt. And unfortunately, a significant portion of Oklahoma's population live in poverty and depend on social services, depend on Medicaid. Medicaid in Oklahoma only covers emergency extractions for adults. And currently, Medicare does not offer an extensive oral health benefit. Oral health coverage and services for pregnant women enrolled in Medicaid in Oklahoma, those services were cut several years ago, along with school-based oral health education that was administered by the state. So the state, their surveillance activities were cut as well. They typically do a third grade oral health needs assessment that should be happening right now, but of course, due to COVID and the lack of funding that was available for states to conduct these activities, that unfortunately hasn't happened yet. And due to restrictive supervision requirements, dental hygienists licensed through the state are not utilized to the full extent of their licensure and education, which creates a barrier for access to preventative services in our communities. And according to the oral health report card that some of you may have seen on prior webinars that we did, this report card, which was released by the Oklahoma Oral Health Coalition, said whenever we're compared to the nation's performance on 13 key oral health indicators, Oklahoma scores a D. And in many of these indicators, we score an F. So, and then, like I mentioned on the previous slide, according to a report that we will be releasing soon, hopefully in the next month, by the Native Oral Health Network, American Indian Alaska Natives in the Oklahoma City area, which that entails Oklahoma, Kansas, and Texas, are on average 2 to 3 times more likely to suffer from oral diseases compared to their white counterparts. IHS tribal and urban Indian health facilities within the state have varying capacities to be able to address oral health needs in Native communities, and in most cases, unfortunately, having less resources to treat more disease. So unfortunately, with our current system in place, it's typically the wealthiest and the healthiest are those that are receiving dental care. So as you can imagine, COVID has exacerbated these issues. Many of the free clinics and events where our indigenous go to get dental care have been canceled, but we are seeing tribes call on innovation and new processes to continue to serve their communities. So what we're going to talk about today is one way we are seeing tribes and states address oral health inequities, and that is through dental therapists serving our indigenous population. So with that, enough of me speaking. I want to introduce our first speaker. Thera Bianchi is a program director overseeing the oral health access campaigns at Community Catalyst. Community Catalyst works to ensure consumer interests are represented wherever important decisions about health and the health systems are being made. Before joining Community Catalyst, Thera worked to improve access to oral health as the campaign manager for the Washington Dental Access Campaign. Prior to that, Thera supported and led advocacy efforts in housing and homelessness, child welfare, and early childhood development. Thera holds a Master of Social Work degree from the University of Washington and worked as direct services social worker before focusing her career on public policy. A longtime Seattle resident, she is now a proud Pittsburgher. And so, Thera, welcome. I'm going to hand it over to you.
Thank you so much. Can you hear me okay?
Yes. Let me, I will get your slides up here for everyone.
So on the lines of grace, I think folks might know that originally someone from my team, Laura Hale, was supposed to present, and I am pinch hitting for her because she's out sick. I have a tendency of presenting very fast. It takes me a lot of practice and sort of intentionality to be slow. I sort of refer to my style as a little bit like a rabid squirrel. So if I start to go too fast, just shoot me a note in the chat box, or Brett or or Julie say like, whoa, slow down. And also because I tried to do a full run of this presentation, I just haven't been able to do a full run of it before doing this. And so if I start to go a little long or something, then just let me know, and I can whip through it fast, or if I'm not fast enough, I'll try to. I mean, if I'm short, I'll try to talk slower. So what I'm going to talk a little bit about is dental therapy from our perspective. We do oral health advocacy and are working on dental therapy, and I'll talk a little bit about the why and what that looks like. I did work on dental therapy probably about 10 years ago on the state level, introducing and running a campaign. The organization that I worked for had a strategic plan for undoing institutional racism. So my frame, as well as the frame of the organization at the time, is really around equity and improving overall equity for the policy areas that we worked in. Next slide, please. Today, I'm going to talk a little bit about who we are, what dental therapist is, again, from our perspective, a brief overview of dental therapy in the US, and then at the end, I think after Brett's section, go a little into questions and answers. Next slide. The Community Catalyst, we originally started as an organization soon after or during the process, during the Clinton administration, when they were trying to advance healthcare across the country. And I think most people who lived through that period or were aware of that period know that that effort failed. And at the time, our founders of our organization really saw that there was a completely missing voice from communities as part of that negotiation and process. And they really felt like any place that any healthcare decision is being made, be it in defining a problem or developing solutions, community, those folks who are most directly impacted should be at the table as part of those decision-making tables. Next slide. I'm going to say this really, briefly. I feel like the folks that are coming to this call are working in oral health, are familiar with oral health, and so that we have a problem. Broadly speaking, the way we see it is that our current system is not working for around 1/3 of the population, and that it's not random. It's not every 3 people doesn't have access to care. There are specific populations, communities that have who have the least access to care and have some of the most need. And so that's a structural and systemic problem. And part of what we're looking at and trying to think about is structural and systemic solutions. And again, use the word solution, but we don't see this as the solution. We see this as a tool in the toolbox. And again, I'm going to just sort of probably say this throughout, is a little bit of our bias is, we really feel communities and consumers need to be at a more prominent seat at the decision-making table. In oral health, we really see that more problematic than many other areas. And most issues that I've ever worked on, there's been a solid community voice. There's been groups that, represented communities. There's been kind of that perspective along with industry and providers and insurers, other groups that sort of work on issue areas. Oral health is really is missing more community activity and involvement in working on oral health issues. And so that's really changed, I would say, probably over the last maybe 10 or 15 years, but we still see it as a huge problem in many of the states we work in. Next slide. You all know this, oral health is a complicated equation for family success. It impacts education, appearance, self-confidence, employability. This has an overall impact to income. It just really is interconnected with every other area of our lives. And it's really important that we and other folks that we're sort of working with start to elevate the importance of this. Because we never go into a community where people don't understand the importance of oral health. What I do think is we find is folks don't necessarily, there's not broad conversations about the way it impacts so many different levels of our daily lives. It's definitely considered as separate. And we really found when I was working on the community level, when we went into communities and asked them what their top healthcare needs were, oral health was oftentimes not talked about. When we asked about oral health, it rose oftentimes to one of the top needs. And so really, we as a sort of society and community remove oral health from our overall health in our conversations. Next slide. The impact of this, of course, you all know, and something that we're sort of talking about more and more because we're sort of seeing that this resonates with people, is that the links to all of these things has really an economic impact that impacts our communities. And we're finding that people are paying more attention to it from that perspective. Next slide. So what is a dental therapist? These are not counselors for your teeth. They're not going to massage your teeth, although I don't know, that could be a good idea. I'm not sure. It's a terrible name. We all know it's a terrible name. Every time I sort of talk about this over the last 10 years, people have been like, why don't just call it something else? We didn't create it. The dentists who brought this over, the tribal leaders that brought this over did not create the name. This is a provider that's been working around the world for close to a century. I'm not sure if the first program was in 1920 or 1922, but it's been around a century. And so we are the last, one of the last countries to sort of bring it over. I think it's in 50 plus countries, and included to be part of the dental team. They've been practicing in the US for around 16 years, but they are reasonably a new provider in the US. They work similarly to the way of physician's assistants. I wouldn't make them analogous to a physician's assistant, but they work similar to the way a physician's assistant works with the dental team. Next slide. Dental therapists in general, I'm not going to go super into this. We don't have one of our practitioners presenting with us. I said that as though Brett and I are presenting together, which we do sometimes. So I'm not going to go too much into the actual scope. They do around 50 procedures, and there's some overlap with dental hygienists and dentists. I would say within that, what they don't, they're not experts on soft tissue, so they're not dental hygienists. They have some awareness of that, but they're not experts in soft tissue. Dental hygienists really are, and they're not experts in the majority of what dentists do. They have a very small scope that is some of the most common procedures. Some providers across the U.S. are dually trained or advanced standing, which means they are dental therapists and dental hygienist, and they have both of those scopes, and they do both. But the dental therapists that have only the dental therapist training have just a small overlap with dental hygienists as far as the amount of time and the level of expertise they have around some of those areas. So it is an additional provider practitioner that works as part of the team. And I think Brett's going to go into that a little bit more, and I will talk a little bit more about that. And then again, if you guys want to dive deep on that, we have some handouts we can share later. And then again, I think that can be best be served by dental therapists talking about it, or some of the dentists or dental hygienists that work with them. Next slide. Really quick snapshot, which I mentioned, dental therapists have been working in the US for 16 years. They're currently working, actively working in 5 states. Actually, that's 6 now. I didn't update this slide. Maine just had its first dental therapist that was hired by an FQHC there, and they're authorized in 7. If you look at this list, you'll see that some of this is in some settings. They only practice in tribal settings in Alaska. They only practice in tribal settings in Washington. And part of this is there's been a slow rollout of these providers, but all of those states are looking at expanding them to be part of broader settings. And there's approximately 160 dental therapists working in the US currently. Next slide. So I'm going to go a little bit into the what around dental therapy. Like, what is the problem dental therapy was aimed to solve? And part of the reason why we feel like it's really important to listen and include community input at every stage of a process, and that is from defining a problem to identifying workable solutions, is because we think the solutions can be more responsive to some of those expressed concerns. And so I'm going to unpack dental therapy from those perspectives in the next few slides. And I think this is really important because from our perspective, the leadership from the Alaska Native tribal leaders and the way that the program was designed, although it was very unique to what the problems they were trying to address there. We have seen in our work in the lower 48 that those are problems that many clinics in many communities are facing as well. And I believe that the overview that Julie gave in the beginning is a clear indication of where some of those problems exist. So again, from our perspective, we see dental therapists as a community-informed solution. Next slide. The community-informed scope, being very responsive to what the folks, the program first came to the Alaska, were looking at is there was a need to have practitioners. And so what they were finding is they had community coordinators, they had community connectors, and that was okay. But when folks are dealing with a number of sort of those complexity of issues that we talked about a little bit earlier, it can be very difficult to have folks come back for subsequent visits. As a matter of fact, community members were finding it offensive and frustrating that they were coming in for appointments and then that connector wasn't actually dealing with the acute need. It would be very difficult for those folks to come serve those patients again. And so there was a delay and gaps in time where those folks were getting worse and worse as far as their dental care. So in the original design of the program, the goal was to actually have a provider, a practitioner that can deal with the acute need. So there are not many dentists. Dental therapists are very different by design. They're intended to be a community provider. They're intended to be do education. They're intended, as the educators first identified with this program, to put the tools down and have a conversation. This is really important. I'll talk a little bit about this later. In communities that have generationally had lack of access to care, there's a ton of distrust and mistrust around care. There's a ton of dental fear. And so having providers that are really focused on using motivational interviewing, developing that relationship, that being part of their role in their job was really important for the initial design of this provider, and the ability to deal with a small handful of the acute need. Dealing with cavities earlier, catching them earlier, dealing with them earlier, dealing with some procedures and doing some procedures that alleviated pain, and then doing education and not doing it the other way around. And so they're really trying to flip that original model on its head. So again, going back to what they're sort of listening to the community and sort of hearing what they need, then wanting to not just have a community connector, which is very important, a very important member of the team, depending on how you deliver care in your particular model, wanting to have a care that a provider that is a practitioner as well as that community level provider. Next slide. Oh, and just that's Aurora Johnson. And I can't remember the person to her left. I'm not sure if that's another dental therapist, but Aurora Johnson was one of the first dental therapists that worked in the US. I think she was at the second training class that's been trained. She's been providing care for her community for the last 14 or so, 15 years. Actually, I guess probably 15 years now. Next slide. So community-informed delivery. Again, talking a little bit about earlier, I'm a person of privilege. I absolutely can take time off of work. I can get to an appointment. I've been able to live and put my, and I am located very closely to my healthcare needs. Many people don't have that. Many people can't take off of work, don't have the transportation. They're not community providers in their communities. So, the traditional model, as they were sort of saying, is provider or people needing to go out and find the care, travel long distances, or wait long periods of time for those providers to come to the community. And so when you look at the delivery model, the goal was to really have providers that lived and worked and stayed in those communities, or would get around those barriers and take care to the community members, as opposed to the onus or the burden being on those folks that were having trouble to get care. So again, part of this is around listening to communities and figuring out how to get around some of those things in order to provide a different kind of care. Next slide. Community-informed workforce. I touched on this a little bit earlier when I was doing outreach, when I was first working on oral health and going out into communities, and when we talked with the tribal leaders. When I was working on the first started working oral health, the tribal leaders in Washington were some of the first meetings that I had when I started this work, and I talked a lot about dental therapy with them and spent a lot of hours talking with those communities on the why of dental therapy, and talking about the historical trauma in the dental fears in relationship to those communities that have had historically not had access to care. It was really important to make sure that this provider reflected the community. Again, completely flipping the way we do things traditionally on the head, as far as like there's so many fields that are trying to quote unquote diversify the workforce. What this is doing is taking a need within the community and taking folks that are linguistically and culturally fluent in that community, and then giving them the skill set and the education and the needed training in order to solve a problem in that community. We often get the question around, is this, yes, but is this separating them from dentists? Dentists are at every part of this. These providers cannot practice independently. They are actually an extension of the team and are regulated and sort of determined how they can work with that full team. And so the goal is really actually to connect communities and providers with the team and have it done in a culturally and linguistically respectful way. And so the other piece that really mattered was trying to create a way to keep those providers in the community, and by hiring and training and working with the community, what they have found is those community members are more likely to stay. They're more likely to continue serving the community, and so the job creation it makes a big difference. They're now leaders in their community, and the economic impact is significant. I feel like it was a super important point that I wanted to make, but I just lost it. So anyways, the way that this happened was really through a strong partnership between the education providers, community institutions, and funders in order to get this first program off the ground. So collaboration and partnership was really a big part of how this first happened. And I think even dental therapy programs that are growing today, you're seeing those same partnerships that are happening to make these programs really work. Next slide. Lieutenant Governor Davidson has been a strong advocate and proponent of dental therapy. She was one of the first folks that I think really was a spokesperson for talking about the difference that dental therapy was making for the community. And so I want to do this short clip on sort of what I think center us on the kind of results, because I'm about to go into a little bit of the results section, and I think she can articulate way more what the goal and point of this program was than I can. If the video works, but I said I would do a tap dance if it didn't.
Okay. Okay, I think we can get it to work here. All right, let's do this. Thank you everyone for your patience. Oh, hold on just 1 second. Sorry guys, let me try this one more time.
Was a child, they would come and round us up at the school, and we would go to the clinic and we would stand in line. In a matter of minutes, we would hear screaming behind that door because their teeth were being pulled. One kid would always run away, and our community health practitioner, Clara Morgan, she'd come and find us, and when she brought us back, we would move to the front of the line, because as terrifying as it was, it's not as terrifying if you don't have to wait as long. We knew that there had to be a better way. My children were the second kids to be seen by the dental health aide therapists who were trained in Alaska. My mom and I were both there, and I looked at her, and she had tears in her eyes. I said, "Well, why were you crying?" And she said, "Because I know that my grandchildren aren't going to have dentures like me." That's the kind of connection that's going to change our world.
So I think the reason why that's really important is because I think, we talk about improving access, and we talk about, these other things. And what this really is about outcomes. It's about improving outcomes. I came from a family also that was impoverished, I would say. I'm not sure how my grandmother would describe the way we grew up, but I would say impoverished. And the stories that we had around oral health was that you keep your teeth until you can't afford them anymore. Everybody in my family expected to have dentures, because there comes a point where keeping your teeth was too expensive. I have the privilege of having my teeth. But again, I think the really important message here right now that's being talked about is it's not about improving access, it's about improving outcomes. And the way that the dental therapy program is doing that is these community-based providers are changing the relationship that some of these communities that have historically not had access to care, they're changing their relationship with oral health care. I think I remember the story that I was going to say earlier when we were talking about these dental therapists actually living and working in the community. The difference of having someone who lives and works in the community, when you talk with the dental therapists that are serving in their communities, they're talking about shopping at the same grocery store, that they walk into the local grocery store and they see that, they see their kids going for soda, and then they look at the dental therapist and they pull their hand away. They're like, they have a little bit of like, oh yeah. And you talk about not being able to get their educational program into the local school. One of the digital therapists joined the school board and got her program into the local school. Another community didn't have fluoride. The dental therapist advocated and worked to get that fluoride in that community. That's the difference in having providers in communities. And so I think that, again, I've worked on this issue for a little over a decade, and there's always been sort of this separation, right? In the lower 48, particularly non-tribal communities, there's been like, oh, but we're not Alaskan, there's difference. I could go into a whole little rant about how I think there's a little bit around racism, that there's sort of this separation from tribal communities. But what I'll say right now is what we saw is a model that has worked in some of the most extreme settings, and those are problems that we're having across the country in many areas. The model that allows you to deliver care through a dump plane across the tundra in a small village in the sort of outermost places of the country is the same model that allows you to deliver care across the street. It's the same model that allows you to deliver care in a satellite clinic across town. It's the same model that allows you to deliver care in a community that's a neighboring community that currently you're not able to reach. And so even though it's extreme, the fact is we have some of the same problems, and toothache is a toothache, and the barriers for that person getting that toothache relieved are some of the same barriers that are being experienced from the folks that initiated this program. So incredible leadership and innovation from the founding folks that brought the program to us. Next slide. So results. So I felt like that was really important to frame it. Early results were sort of showing that providers were getting quicker access to care, and so they didn't have to travel as far. Their waits to see providers were shorter. They were getting to spend more time with providers, and that they were diversifying the local workforce. And so those were sort of early things that they were seeing. And they were able to get more people to get care. And these are private practice and clinics. Private practice dentists, and when it was originally sort of brought to the local 48 in Minnesota, were heavily opposed to this. They're now one of the largest employers of this. So there's some resistance in many places, but once folks get to, I think the biggest inoculation to any sort of concerns or fear around dental therapists is meeting and talking with and learning about the dentists and dental therapists that are doing some of this work. Next slide. And this just goes back to what Davison was talking about, and that is the results. And so yes, improved access, but what they're finding is that there is more adults and children who are getting prevention and keeping their natural born teeth. So there's a clinically significant difference. And I pulled this slide right from Dr. Donald Chee's study. He is the one that led the study of the 10-year study of the Alaska program. He walked in skeptical and wasn't really sure that this was going to make a difference. When I asked him, give it to me in sort of like layperson terms, lowering 1.9%, like what does that mean? So he spelled it out here, reducing. When you look at a population of 2,500 Medicaid and rural student children, that's like making it from 200 folks that are getting their teeth pulled to 50. And then I asked him again, like, what does that mean, to you and all the things that you're studying? And he says he hasn't studied anything else or found something that's making that level of a difference, maybe other than fluoride. So for him, that was a real game changer for him, like just seeing that this is actually making an impact. So again, going back to the earlier thing, it is ending up in people having better outcomes for their communities, and it is clinically significant. Next slide. I think I sort of stressed this a lot. I think I actually might, this is probably a slide that I put in a number of other presentations, but I would just say, that this is an important aspect of this. This is Conan Murat. He was one of the first dental therapists training in Alaska, and it, again, is one of the longest serving dental therapists in the country. Next slide. Support for dental therapy is growing. We really can't keep up with the folks that are interested in learning more about this. We're not saying that this is something that every community needs or wants or should be using, but we do think that every community should be able to have conversations about this, explore it, and decide if this is right for them. That even if some folks within states don't want it, there's a number of states that do. We've actually found that there's broad support. I would even call this bipartisan. I would call this a nonpartisan issue. More than anything else we work on, we've never seen people from across such political spectrum support this particular issue. There has been some opposition from dental associations. We've seen some softening and changing of that. We've actually found that there's just a ton of misinformation about this provider within the dental community as well as other communities. And so it's really important for us, we think, to do outreach and have some conversations and sort of demystify what this provider is really doing. Again, you go back to some of the strongest supporters at this point, and there's some of the folks that opposed it many years ago. Next slide. The Natural Partnership, we started this, I think, a little over a year ago, could have been a year and a half. And it's really to start to create a landing place and a hub for many of the folks that we hear from. And so we get a ton of requests and questions from community groups. We get a ton of questions and from tribal governments and tribal organizations. And a regular connection from dentists. So the three co-chairs, Brett from the National Indian Health Board, who's on my screen right above me, and us, Community Catalyst, and there's an organization, the National Coalition of Dentists for Health Equity, and that's a group of about 75 dentists that support dental therapy, but also are looking at a number of health issues and policies and developing positions on why folks should really be considering these things to advance oral health access and equity from the dental perspective. So we encourage you to come to the site, and also, if you guys have any questions, then please feel free to reach out to Brett or myself, or Julie can connect us. Next slide. That's the amazing group. We just had a convening not too long ago, and this was a group of dental therapists from all of the states where they're practicing. And so the top row is the first 4 dental therapists that were trained and have been practicing in their community for, I guess, what is now 16 years. So they're still out there, still providing care for their communities. And that's it. Thank you so much. I hope I was right on time.
Awesome. Thank you so much, Thera. That was very informative, a lot of really, really good information. I want to, I know I said questions at the end, but just because there was a lot of information, some folks might have some questions now about Thera's presentation. If you guys have any questions, will you put them in the chat box? And you can also feel free to unmute yourself as well. But I'd like to see if there's any of the attendees that have any questions specifically for Thera before we move on to Brett from National Indian Health Board. And if not, I have a couple. Okay, so I'm fairly familiar with Community Catalyst and your the work that you guys do, Thera. And I know you stressed a lot on your presentation about the consumer voice and the community voice, and kind of uplifting that, and getting feedback and having them being in the center of kind of creating a lot of the movements and policy, even outside of oral health, right? So my question is, so what, in a nutshell, because I'm assuming it's probably looks different across, maybe across disciplines, but what's the process for getting community input and getting that community voice? What does that look like as a, from more of kind of like a work plan kind of tangible aspect? What does that look like?
Yeah, I mean, that's I would say from our sort of perspective and kind of model of doing this work, it's all about partnerships. And so there's groups that are very good and connected. Some of them are doing direct work with communities. It's around advocacy. Some groups are represent community groups. And I would say that there's a really strong and important relationship between those folks that are actually providing care and doing services. And, part of the reason why I stressed that I was a direct service social worker and that moved into policy is because I was delivering care and doing work that I was seeing was not working. I had a full-time job, so me connecting those folks to an advocacy effort was not something that I can do. So it was really important to have partnerships, working with groups that are doing community organizing, working with groups in an ethical way. There are some times where groups, tokenize communities, kind of like, we think this is a good idea. Can you come and talk about, your particular, problem? And again, this is why we think it's really important that communities are part of the definition of a problem, the designing of the solution, and then advocating for the solution, because we want it to happen in a really authentic way and not sort of make, poster children, if you will, or tokenize communities that have, are having difficult needs. So I would say that if you're in a place where you're trying to work on something, and I say this to like everybody that's, tuning in, if you will, and your direct group doesn't do that work, then it really is about building some of those partnerships and coalitions, like looking at who's at the table right now and who's represented and where are the gaps, and then doing a little bit of your homework on seeing who's connected to those groups, and then what those groups know around how to bring folks to the table, and are they doing it in a genuine way? Like grassroots organizing takes real effort and capacity, and is a strong skill set. I am not a grassroots organizer, and if I was looking to do that, I would actually look with groups that are actually doing that in an authentic way. So I'm happy to sort of talk a little bit more about that, and we can go into it more. And I could do a whole nother hour on that, but I would say that a part of doing successful advocacy or working on issues is really finding those key partners that have aligned values, that are sort of working on the same issues as you, and working closely with them. And also there's also a whole process in working with folks that you normally don't partner with. Again, I don't think Grover Norquist and Bernie Sanders are going to be sort of hopping on the same train to do a lot of work together, but they can work together on issues. And I think it's something that might be getting lost in our current world, but it is really important that we can work together in order to find solutions.
Awesome. Yeah. Thank you so much, Thera. Okay, so if we don't have any questions, which doesn't look like we have any in the chat box, then we're going to move on to Brett. Let me get your slideshow up here, ready to go. So Brett Weber has worked with the National Indian Health Board since October 2016, and he's focusing on the Tribal Oral Health Initiative. Brett's work seeks to find solutions to poor oral health outcomes in tribal communities through workforce development, culturally competent provider models, and increased investment in the oral health care delivery team. Brett also worked on legislative priorities of the National Indian Health Board and now works to grow NIHB's environmental health expertise. Mr. Weber graduated from the University of Georgia in 2014 with both a bachelor's degree in political science and a master's of public administration. He is a former fellow of the United States Senate Committee on Indian Affairs and intern at the White House Office of Intergovernmental Affairs in 2015. So without further ado, Brett, welcome.
Great, thank you so much, Julie. And as Julie mentioned, I'm Brett Weber with the National Indian Health Board. And Julie, it doesn't look like.
Let me get your,
okay,
I think I started off on the wrong, hold on just a second, I'm sorry.
No worries. But as Julie mentioned, I am with the National Indian Health Board. And for those of you who are not familiar with NIHB, we are an intertribal organization. We're based in Washington, D.C. Despite my Zoom background, I am not, in fact, north of the Arctic Circle right now. I am in my dining room in Washington, D.C. So we were created in 1972 by a group of tribal leaders to be sort of a unified voice. And historically, when tribes were the most successful in negotiating with the federal government, they were at their most unified. And so that same principle carried over. And so NIHB was founded to be the unified voice of tribes at the national level for health issues. And that's not just limited to healthcare. We do a lot of work with the Indian Health Service, certainly, which is the federal agency that is tasked with providing healthcare services to American Indian and Alaska Native tribes. But we also do a lot of work in the public health sphere. Julie mentioned I'm working on some environmental health issues as well. And so we work with a variety of federal partners, whether that's the Centers for Disease Control and Prevention, or HRSA, the Health Resources and Services Administration, SAMHSA, the Substance Abuse and Mental Health Services Administration, and other agencies. So we do a lot of work, and as Julie mentioned, I do wear a number of hats, but working on the Tribal Oral Health Initiative is something that's near and dear to my heart. We created the Oral Health Initiative in 2011 or so to sort of look at solutions for Indian countries' oral health crisis. And I use that word, I don't use that word lightly. It's a crisis, as are many other health issues in Indian country. And I'm going to provide you some statistics that are Native specific. However, if you do work in this space in tribal oral health, you probably already know the situation. So I think with that, we can go ahead to the next slide. And so Thera already mentioned some of this, but as Julie mentioned, we're all on webinar mode. And so I just want to make sure that if you're new to this issue, you really get some takeaways. So I'm going to repeat a couple of things that Thera said because they are so important. So Julie, could you advance? This one is a living slide. So dental therapists are mid-level focused providers. You can sort of think of them as the nurse practitioners or the physician assistants of dentistry. That analogy isn't 100%, but it'll serve for the purposes of this webinar. Dentists using the Western healthcare model do about 500 procedures. Dental therapists can do about 50. That doesn't sound like a lot. They're only 10%, but that is enough to meet. Julie, could you advance? That's enough to meet between half and 2/3 of patient need. Those 50 procedures within a dental therapist scope are the most commonly needed. And they focus on preventative and restorative services. Within the Indian health system, that's closer to 2/3 of patient need that's able to be met by a dental therapist because so many of the cases that Native people present at a dental clinic are issues that are developed from a lack of preventative and routine maintenance. So that's something that a dental therapist can service. And generally speaking, under the supervision of dentists, dental therapists can practice in remote settings with need for additional provider capacity. So, we're not talking about, okay, I'm a dental therapist, I'm gonna establish my own practice and be a dental therapist. They all have to work under a supervising dentist. Evidence, and don't take my word for it, there are, I think, 1,100 studies or so, shows that the care provided by dental therapists is high quality, cost effective, and safe. Those resources are available on NIHB's website, and I'll give you the link for that later in this presentation. So you'll see here a lovely colorful map. So dental therapy is, dental therapists are licensed by the state, although I'll get into a little bit more about how that looks like at the tribal level, but licensure is often a state issue. So we go state by state here. And so on the kind of bluish color, bluish purple, Alaska, Washington, Idaho, Montana, those are dental therapists that can practice in tribal settings. The green, the Minnesotas, the Michigans, et cetera, those can practice statewide, and that's licensure. Oregon has a pilot project where dental therapists can practice, and the orange states either are considering or recently considered dental therapy licensure bills in their state legislature. So you can see, the states of Connecticut and Idaho, politically speaking, don't have a lot in common. Connecticut's pretty well-off and suburban and fairly liberal. Idaho is very rural, very conservative. But they both agree that dental therapy, at least in some settings, is a solution to oral health challenges. And that's, to reiterate a point Thera made, that's one of the reasons why I really love working on this issue. I mean, especially with healthcare, it gets political real fast. But dental therapy is really an exception to that. The Trump administration actually wrote a document around dental therapy that honestly, like Thera and I could have written. It was so favorable to dental therapy. And then just recently, the Biden campaign announced its support for dental therapy as a solution to oral health. So, you know, even in the midst of a presidential election, we still see that there's bipartisan and as Thera said, even nonpartisan consensus around dental therapy. So it's a really fun issue to work on. However, a less fun statistic is, like I said, the oral health crisis in American Indian and Alaska Native communities. There are some statistics that you can see on the screen. This data comes from every now and again, the Indian Health Service does I think they call it a survey of oral health in tribal communities. They don't do it regularly. It'll be somewhat periodic. I think they did one in 2017 and 2019, I believe. They're on our NIHB's website as well. But the takeaways are that, you know, American Indian and Alaska Native children are 5 times more likely than average to have untreated cavities in permanent teeth. And that's permanent teeth, right? That's not our baby teeth. And then almost half of our elders have untreated dental cavities. And that's more than double the rate for non-Native seniors. And so this is impacting children and elders and everyone in between. It's hurting generations of people. And why is that? Well, one of the reasons is the average dentist in Indian country serves 2,800 people, and that's almost double the per capita load of a dentist in the non-tribal health system. The national average is about 1 in 1,500, but in Indian country, it's 1 in 2,800. And go ahead to the next slide. And I want to explain this graph a little bit. So the Government Accountability Office, the GAO, is an entity, an independent entity that responds to basically questions or concerns that Congress or the administration have with a particular issue. And so in 2018, a GAO was asked to look at provider shortages within the Indian health system. Now, if you don't work in the Indian health system, there's basically 2 ways that, that this works. The Indian Health Service operates hospitals, facilities, and clinics itself and provides those services directly to tribes. And so those are called direct service tribes. And another way is tribes have the option to operate their own health systems with funding from IHS. And those are called 638 or self-governance tribes. So this chart is just looking at that first group, the direct service tribes, looking at IHS facilities. And you can see, it might be a little hard to read on your screen, but in the Oklahoma City area, IHS has 42 dentist spots and 10 of them are currently vacant, right? So that's 25% of spots are unfilled. So it's pretty safe to say there's a provider shortage. You're not as bad off as Bemidji, where 7 out of 18, more than a third, are vacant. But still, Oklahoma City, that is an area of concern, the lack of dentists in direct service facilities. Go ahead to the next slide. So let's talk about how a tribal oral health team operates and how the dental therapists fit in. And you can see some acronyms, but don't worry, I'm going to walk you through this. So community health representatives, which most tribes utilize, they serve as sort of patient navigators, and we see a similar role with the dental health aides under the community health aid program, and that's in Alaska. And they really work to help patients navigate systems and access care. So if a patient has trouble making an appointment or can't arrange transportation, the CHRs and the DHAs are helpful in that work. Community dental health coordinators do education and outreach. This is utilized on Navajo, and I think Chickasaw in Oklahoma as well utilize the CDHCs, the community dental health coordinators. And those, again, are focused on education and outreach. So they will go to schools and talk with students about the importance of maintaining teeth and visiting the dentist regularly. Some can do limited preventative work, but it's mostly education and outreach that they do. Of course, hygienists focus on prevention and soft tissue. And then dental therapists can see preventative and common restorative cases in a variety of settings. So they can go into, they're usually clinic-based, but they can travel to a senior center. They can travel to, a Head Start program to provide services to the children there. And then a dentist can devote time to the really complex cases in the clinic that only his or her scope is able to serve. So, at NIHB, we take an all of the above approach. We're certainly in support of all of these. Each role is important. The thing that we really like about dental therapy is that when someone comes to the clinic and says, "My tooth hurts, can you please help me?" The dental therapist and the dentist are going to be the two roles that can really help the most. And help remove that pain. And what we see in Alaska, where dental therapists have worked since 2004 in tribal communities, is that the dental therapists tend to come from the communities that they serve. And you'll remember Lieutenant Governor Davidson's recounting of her childhood growing up in an Alaska Native village, when the dentist would come, and when in Native Alaska villages, for those of you who are not familiar, they're very isolated and very tough to get to. They're not connected via a road system, so you have to fly in, or if they're by water, you can take a boat. But so regular dental access was, with the Western healthcare model, is not realistic. So a dentist would periodically fly in, and when I say periodically, maybe every 6 months, maybe every year, would fly in. And by that point, you don't have time to focus on, okay, well, let's do a preventative treatment plan. No, I'm there to pull teeth. That's what I'm there to do. And so that's what their experience was. And that's frankly a traumatic experience. That people in Lieutenant Governor Davidson's generation grew up with that. And it's very tough to develop a healthy disposition towards oral health when that is your experience in the dental chair. So what we like about dental therapists is that they're able to develop a long-term preventative treatment plan for patients, and able to treat cases before they get to that emergency care that Lieutenant Governor Davidson talked about. So each role is important, but dental therapists are a really, really important part of this that we want to make sure is available to all tribes. So go ahead to the next slide. So I mentioned Alaska's program. So Alaska's dental therapy education program has been up and running for more than 15 years now. And they actually educate their students through their dental therapy education program, which was just accredited by the Commission on Dental Accreditation. And what they found is that more than 90% of students are American Indian and Alaska Native. And, not that this is necessarily a bad thing, but dentistry is a disproportionately white profession. It's disproportionately male as well. And just to be honest, it can be tough for non-tribal providers to develop a rapport and build trust with a tribal population, particularly when they're operating with very constrained budgets, they're overtaxed, they're overworked. Burnout is quite high amongst healthcare providers. So having a workforce that comes from the community it serves has really made a big difference. And I want to say, and Thera, you can correct me if I'm wrong, but I want to say the retention rate for Alaska dental therapists is over 80% over 5 years, which is pretty high compared to other professions. It is an accessible profession with steady work. The Alaska program is a 2-year program. For many people that have family ties that are tough to leave home, a 4-year college is not necessarily going to be something that they're interested in or that they're able to take on at this period of life. But 2 years and you don't have to leave the state, that may be something to look at, because the first year in this particular program, the first year is in Anchorage, Alaska, and then the second year is in Bethel, which is a hub community in the southwest part of the state. So it's a 2-year program that is more accessible. And as we see dental therapy spreading, you saw the map earlier of how many more states are interested in it now. There are programs being developed in the Pacific Northwest and in New England. And tribal colleges are also looking at how to develop programs too. And NIHB is working to support those tribal colleges. Of course, there are significant startup costs. So, so we want to make sure that, you know, as the education infrastructure for dental therapy is built out nationwide, we want to make sure that our tribal colleges are not overlooked from that discussion either. Can you, perfect. So, okay, so I hope Thera and I have sold you on dental therapy at this point. And we're looking at now how tribes can employ dental therapists. And the short of it is that there are 3 possible routes. The first is the Swinomish way. And, you know, tribes are sovereign nations and they can develop their own licensing infrastructure. And so Swinomish did precisely that. They said, you know what, we want this model, it'll work. We're going to license this provider to be a dental therapist. And that license will, you know, for the purposes of Swinomish reservation, be a sufficient level of certification. So tribes have that right. And you can see the picture on the bottom is the Swinomish Dental Therapy Licensing Board, which is full of the nation's preeminent experts on dental therapy issues. There's some real heavy hitters in that photo. However, I will say the Swinomish route took quite a long time. It took sustained administrative support from the tribal leadership. And of course, that license is only valid on Swinomish. So if other tribes want to develop this, they have a couple different options. They can either look at what Swinomish did and build up their own infrastructure, or they can actually sign reciprocity agreements and say, okay, well, if you as a provider are licensed by Swinomish, my tribe will also recognize that license. And there are a few tribes that have done that. Of course, not every tribe wants to do that because it is, you know, it does give another tribe's licensing board authority. So not every tribe is going to be interested in that, but if a tribe is interested in that, that is one way you can go, is the Swinomish route. The second way is state licensure. And so that's, you know, as Thera and I mentioned, there's, you know, state licensure is typically a state issue. When you're, my mom, for instance, is a licensed clinical social worker. Her license comes from the state of Louisiana, and so on and so forth. So a tribe could hire a dental therapist with a state licensure. And of course, complying with any sort of requirements that the state includes in its licensure law. The third way, and this can be a little complicated. So if anyone has any questions, feel free to send me something in the chat or just ask me to repeat. So remember how I said that DHAT, the Community Health Aid Program, was servicing tribes in Alaska. Well, IHS, in 2010, Congress gave IHS the ability to expand CHAP. And they said, you know, CHAP is doing really great things in Alaska. And CHAP is composed of medical, behavioral health, and dental components. So Congress said, IHS, you know, you can expand CHAP nationwide. You now have that legal authority. In 2016, IHS says, okay, we will now expand CHAP. And over the past 3 years has worked on a policy to govern how CHAP will be expanded to tribes outside of Alaska. So the way CHAP providers are certified is because CHAP is a federal program, the providers are certified by the federal government. They don't need to go through a state licensure. However, there is a restriction on that. So remember how I said CHAP has medical, behavioral, and dental components. When Congress gave IHS the authority to expand CHAP nationwide back in 2010, they included a restriction, and it only applies to that dental component, and it only specifically applies to the dental health aid therapists, so the dental therapists working under CHAP. And so you can see the federal citation there. So once CHAP expands to the lower 48, tribes can only use dental therapists under that program if their state gives them permission. So that's obviously super problematic. What did I just say at the beginning of the slide? Tribes are sovereign nations, right? So it's extremely inappropriate for Congress to give that authority to states over tribes. Again, National Indian Health Board being a national organization, we have been working to get that issue fixed. Legislatively, it is a long road to hoe, so it'll be a bit before we get that clarified in federal law. And so that's one of the reasons why tribes are so eager to partner with groups like Community Catalyst, and why we need the National Partnership for Dental Therapy, because suddenly, if we want to use a federal program, we now have to go through the states, the same as any other groups. So we partner with states and state advocacy groups to pass dental therapy legislation. Can you go ahead to the next slide? So again, licensure by state law is going to be the most common way, because again, that CHAP requirement does require state licensure. 13 states have some mechanism for dental therapists to practice in tribal health systems. And again, it's the same as any other medical professional. And this is an option for 638 or those self-governance tribes that run their own programs. The two things that they would need to work out is, every year when they do their annual funding agreements with the Indian Health Service, the positions of dental therapists will be reviewed by IHS, and then securing Medicaid reimbursement from the state plan amendment. And this might be a little too technical, but this is just something to keep your eye on. As Medicaid reimbursement is also something that, it's not a barrier necessarily, but it's something that has to be worked out before the tribe can utilize dental therapists. Okay, so let's talk a little bit more about CHAP, because I know that's kind of a complex issue. And so again, just bears repeating, CHAP provides frontline healthcare services to Alaska Native communities. And this is actually a living slide, Julie. So do you mind just hitting next a couple times? Perfect. And I think one more time. Perfect. Okay, that's it. So again, like I said, IHS expanded CHAP to tribes outside of Alaska. They spent 3 years working on the policy. So it was quite a while in coming. So that policy was published earlier this year in July. And as part of CHAP, there are about 40 dental therapists, and they're called dental health aide therapists when they work under CHAP. For the purposes of this presentation, I'm just going to call them dental therapists. They provide services to over 45,000 Alaska Natives in 81 communities. And how it works is, again, those communities are not connected via the road system. So the dental therapists are based in larger towns that also have dental clinics, Bethel, Sitka, Nome. And when I say larger towns, these places have a population, 10,000 at maximum. Bethel has about 6,000. So they're still fairly small. They travel to smaller Alaska Native communities on a regular schedule. I was lucky enough to travel with a dental therapist named Savannah from Sitka to Cake, and you can see that map in the Cake and Sitka are in the southeast part of the state. So I flew with her and saw her practice, and she visits Cake, which has a population of 500 or so every month. She's based in Sitka, but every month she flies to Cake, and she's able to provide that long-term steady treatment and preventative treatment plans to patients in Cake. And if she encounters someone that, she says, this is a really complex case, it's not within my scope, a dentist can follow up when necessary. A thing that we often overlook, a thing that we often stress in tribal settings and often overlook in non-tribal settings, is the importance of cultural competence. If I have a provider that isn't speaking to me in a way that is relevant to me or isn't really reaching me, his or her treatment is going to be less effective than as someone who understands where I'm coming from, someone who's lived my experience. And we find that within Alaska, about 3 in every 4 DHATs or dental therapists practice in either their home village or their home region. And as Thera mentioned, that study from the University of Washington, which is on our website and on the National Partnerships website. I'm not going to give you the exact statistics, but for simplicity's sake, we did see an increase in preventative care and a reduction in the amount of emergency care needed. So again, Congress gave IHS the authority to expand CHAP in 2010, and IHS did that starting in 2016. The IHS created the CHAP Tribal Advisory Group, or CHAP-TAG, which is really fun to say in the Batman voice sometimes. But CHAP-TAG drafted the interim policy along with IHS over the course of about 2 years. And there were some pretty significant issues to work out. But it's pretty good news in 2020 as far as CHAP is concerned, because IHS published a position description and for dental therapists. And the reason that's important is when we talk about dental therapists working at IHS facilities, right? IHS being a federal agency, everyone there is a federal employee, and the federal government cannot hire someone without a position description for that position. And that's everyone from the dentist to the janitor, you know, and everyone in between. So having that position description for dental therapists, being able to work in IHS facilities is really a phenomenal step that we really needed. And I talked with IHS around, you know, how can a 638, those self-governance tribes utilize this? And, you know, IHS says, you know, this is our position description, tribes can use it, that tribes can throw it out and write their own. They can copy and paste, it's their choice. So of course, during the pandemic, IHS had hoped to have this policy in place by the beginning of 2020, but it did slow down due to the pandemic. The policy is now in place and areas can begin establishing CHAP infrastructure. So let's just look at a couple of case examples around the impact of dental therapy. So I'll talk first about Swinomish. And remember, Swinomish was that tribe. They're in Washington State, and they created their own licensing board that developed processes and standards for licensing a dental therapist on the reservation. And you know, it was very important work, and it was very good that they did that. With the caveat that it took years of sustained administrative support from the tribal council, specifically in the tribal senate. The picture on the top of your screen is their original dental trailer, and you can see it's not very large. It would not be able to service a number of people. I forget off the top of my head how many chairs it had, but certainly not enough. They hired a dental therapist in 2016, and in those 4 years, they've seen an overall increase in the number of patients seen by 20%. And the dentists are doing almost 50% more crowns, bridges, and partials. So, you know, because that dental therapist is taking care of the 50 procedures that are able to meet the majority of patient need, the dentist can really focus on the really complex procedures. And that's important for two reasons. One is, of course, the quality of care is the dental clinic is able to treat more people and focus on harder to treat cases. So patients are happier because they're being able to be seen. And then the other thing is from the tribal administrative side. When a dentist is doing more complex procedures, those are the more expensive procedures. So the dentist is able to bill Medicare and bill Medicaid more. And so that increase in revenue brought in such revenue at Swinomish that they were able to support the expansion of the tribe's dental clinic. You can see a picture of it, that it opened in April 2019, I think. So they have a pretty substantial increase in the number of patients being able to be seen. And they've now hired additional dental therapists. I think they're at 3 total now. Next slide, please. So there's a couple other tribes that I want to talk about in the Pacific Northwest. You can see this is Naomi Petrie, who we are very proud of. She's working at her native tribe in Oregon, where she grew up. And she is one of NIHB's original youth policy fellows. So we're very, very proud of her. And so Port Gamble Slalom Tribe, which is in Washington State, has a dental therapist since 2017. And they've reported that their wait times have decreased by almost, I think, over half. So that's what we really see as a benefit of dental therapy is, you know, when we talk about wait times in Indian country, we're not talking about, oh, it's 2 weeks. We're talking it's 4 months, it's 5 months. I've heard 6 or 7 months in some cases in the extreme. So cutting that wait time in half is a really, it can honestly be a life and death issue if the case is severe enough. So cutting that wait time statistic is very important. In Oregon, we see the same similar trends. Dentists are able to dedicate more time to treating complex cases, which is bringing in more revenue, and they're able to add chairs to their clinic and see more patients and kind of cycle it on through. Go to the next slide, please. Okay, so, you know, this is great and everything, but it's kind of tough to talk about anything new during a pandemic, right? Well, first, let me do a short little plug for our NIHB's National Tribal COVID-19 Response Center. You can see the link on your page. Please do visit that site. It has quite a bit of public health information around not just oral health, but around, you know, public health in general during COVID. So for quite a while, IHS and tribal dental systems earlier this year were open only for emergency cases, and we had to rely on teledentistry, which, you know, was kind of splitting the middle there, allowing patients to receive care, but also reducing the spread of COVID and the risk that patients and providers would be exposed to the virus. The real leader here was Lummi Nation, as well as a few other tribes in the Pacific Northwest. And Lummi Nation is in Washington State. So they used runners, and how the runners would be tribal employees who would drive this little dental kit to a patient's home. And then they would set up either through FaceTime or through some other secure video chat between the patient and the dental therapist or the dentist. The provider was able to walk the patient through the treatment plan using that kit. It really worked very well because almost the entire scope of practice for a dental therapist can be done virtually through teledentistry. And Lummi Nation reports pretty high patient satisfaction with that. So it was very lucky that they had a dental therapist and they had a good telehealth system. But we can see how these systems complement each other during the pandemic. Go to the next slide. Okay, so I'm going to give a very brief overview of implementation in just a few states. You know, since this is, you know, mostly an Oklahoma specific webinar, I'm not going to go too far into the weeds here, but you might find it interesting. Certainly, if you have family in these states, you might find it interesting as well. So in Washington State, where again, Thera is an old veteran of this campaign, the state was very supportive of tribal dental therapists, everyone from the governor to the state legislature. They passed a tribal-only law in 2017, so that said, you know, tribes can utilize dental therapists within their own health systems, and then we'll revisit statewide licensure soon. So for now, dental therapists can practice in Washington on tribal patients on tribal lands. Go to the next slide, please. In Arizona, Arizona State passed a dental therapy law in 2018, and that's the first session the bill was considered, which is actually really impressive. For those of you that don't live and breathe state legislative politics, which I can't imagine a more fun topic for anyone, but it is very rare for a state legislature to pass a bill in one session. Typically, there's one session the bill's introduced, lawmakers are getting their familiar with the issue. The second session is more like, okay, we're going to do maybe committee hearings and we'll see if like this really works. And then maybe the third session will pass it. The State Board of Dental Examiners will publish draft implementation rules soon. We have been working with tribes in the state of Arizona to make sure that those draft rules work for tribes because the tribes are very eager to hire dental therapists. They see the success that they've brought to Alaska and the Pacific Northwest. And there are a couple tribal colleges who are interested in developing their own dental therapy education programs. So that's something that the National Partnership and NIHB and Community Catalyst are working on is ways to support implementation. And that's everything from providing comments to the rules to supporting other ways to get dental therapists working in these states. And I think I have one more state to talk about. Yeah, Michigan. So dental therapy passed in Michigan in 2018. It was a very clean bill. Sometimes we'll see there's a bunch of different restrictions, like a dental therapist, can't do this service, or, if you want to do this service, you have to get diagnosed by a dentist first. And, it can be a little cumbersome at some point, but Michigan was passed a pretty clean bill. I will say tribes got it over the finish line, especially the tribes in the Upper Peninsula, because they were so eager to employ dental therapists. For those of you not familiar with the state of Michigan, the Upper Peninsula is very rural and very economically disadvantaged. There are a handful of tribes up there, and they really, their healthcare systems are really the bedrock of the health system in the Upper Peninsula. The rules and regulations from the state are currently being finalized, and of course NIHB and the National Partnership are supporting that effort as well. Next slide, please. So you can see the link nihb.org/oral health initiative. We have several resources that again are tribal specific. We've done several surveys and several policy analyses. We do a quarterly newsletter, and you can see the picture of the newsletter on the left. If you are interested in signing up for that letter, you can send me your email through the private chat, and I'll add you to our listserv. Our next quarterly newsletter is going out before the end of October, so you're signing up at just the right time. Next slide, please. And the last document I want to bring your attention to is the startup guide for tribal leaders. And we, for those of you that work with tribal leaders, they're very busy people, and they're expected to be they're expected to understand a variety of issues. So we want to make sure that they had a document around dental therapy, because I've been talking with you for 30 minutes. Thera's been talking with you. I hope you are pretty comfortable with this issue now, but you can see it's pretty complex, right? Thera and I assure you, could talk to you for hours more about this topic. So it can be pretty complex, and we want to make it a little more digestible, which I'm now realizing I misspelled on the slide, so I hope no one noticed that. And so the startup guide includes concrete action steps that tribal leaders can take in their own communities, sort of, how to engage a dental clinic around incorporating a dental therapist into their scope, how to evaluate whether what the oral health care situation is in their community. That startup guide is available on NIHB's website. I think we have a few print copies, so if you're interested in getting a paper copy, email me and go to the next slide, please. Email that email address, and I'll see if we have any paper copies that I can send you. But that's all I have, and so thank you again so much, Julie, for inviting me to present. And really, I hope I didn't confuse anyone too much, because again, it is a fairly complex issue. So I hope you enjoyed this, and I look forward to any questions anyone has.
Thank you so much, Brett. I appreciate that. That was a lot of really, really good information. I want to I want to open it up to the chat box, to our attendees. Again, there was a lot of information that we just talked about here over the last hour or so. And so I'm going to give you guys some time to think about your questions, put those in the chat box. Also, just feel free to unmute yourself as well. If you, I'd love to hear someone else's voice other than my own. And Brett and Thera, no offense. But yeah, go ahead and unmute yourself if you have a question, or we can get that in the chat box, and Alex will get that out to our speakers. So before, while you guys are thinking of your questions and what you want to ask, or maybe even if we have anyone on the call that can add to this discussion, I would also love for if you guys have any information that maybe specifically relates to Oklahoma, please share that as well. But while you guys are thinking about that, I have a couple of questions that I wanted to ask you both. I'm sure both of you know this, but Brett, I heard you specifically mention CODA accreditation, and that actually just happened, I think August of this year for the program in Alaska. Could you talk a little bit more about the weight and how important that is to the dental therapy movement by that program in Alaska being CODA accredited?
Sure, and I'll take a first stab at this, and then if Thera, if you want to add anything, definitely feel free. So let me back up a little bit. So the Commission on Dental Accreditation, CODA, is the national entity that accredits dental education programs, and that's dental schools, dental hygiene schools, and now dental therapy schools. So in 2015, CODA said. Published their standards for dental therapy education institutions. And that document basically said, if you want to design a dental therapy education program, this is sort of the criteria that you'll need to comply with. And so in that 5 years, the Alaska program predates that by a little bit, but Alaska spent those years making sure that its curriculum was in compliance with the standards and then applying for the accreditation designation. And if anyone is involved with accreditation, it is kind of a lengthy process. There's a lot of boxes to check. But the significance of that announcement, which was, like you said, August of this year, so still very recent, is kind of twofold. One, it lends legitimacy to the program. It sort of says, dental therapy is here to stay. And we, as essentially the national experts on this issue, say your program is good and meets our standards. And the second benefit of accreditation is that, again, with this being with licensure often being a state issue, a lot of states will say, oh, well, if you want to be a dentist, you have to, be a graduate of a accredited dental school. And it's the same thing for dental therapists. If you want to be a dental therapist, one of the requirements is you graduate from an accredited dental therapy school. And we actually see that in Idaho. Their legislature passed a law that said, a dental therapist, and it was tribal specific. It said, if a dental therapist wants to practice on tribal land, they have to be a graduate from an accredited dental therapy school. And of course, at the time, there was no accredited dental therapy school. Now there is. So a dental therapist can quite easily practice in Idaho, for instance. That's just one example. Thera, did I leave anything out?
I think that's right. I mean, I think that one of the things that I'll add to that on why it's important is, sometimes, there's these conversations about, which program is right, because we have a handful of educational programs that are currently graduating students and a couple of others that are sort of developing. And if you've been working on this issue for a long time, there can be a little bit of like either or. And I think what's important about this is that every state kind of and the educational institutions within those states, the tribal colleges, the community colleges, the other, the schools, have the ability to do that. So what's unique and important about sort of like the community informed solutions that I was sort of unpacking earlier, there's a little bit of a misnomer around the program in Alaska as being a quote unquote 2-year program. By CODA standards, it has to be a 3-year program, at least 3 years. And so what's actually happened in Alaska is the local school, again, that collaboration of communities, employers, educational institutes, looked at what's needed in order to start creating providers and educating the providers in our local community. And they developed an educational program that meets those standards, that is crammed into a period of time that they felt that their non-traditional students can be away from the workforce in order to get the education. So it actually is done in 2 calendar years, but it's full-time, year-round, beginning of the day, end of the day program that is rammed into 2 years. Not every community is going to want that program, but what Alaska is shown is that you can create a program that fits the local needs of the workforce of that community, and that can work, and you can get code accreditation. So as communities across the country look at this, what Alaska has shown is like you can create that localized problem, add to the workforce with that. There's a bunch of different kind of programs. Every program that exists right now in the U.S. can be a coded accredited program, and it's really about making sure that the full state has the full range of being able to do that. And what Alaska has done, and that code accreditation has done, is shown that you can be innovative in order to make sure that your state and your local communities can build a program that works for them. I don't know if that makes sense, but I think it's just a phenomenal and important milestone on the profession of dental therapy.
And I'm sorry if you guys mentioned this before, but is this the only dental therapy program that is CODA accredited? It is. Okay.
I think there's 2 other schools that have had their applications ready. 2 applied in both of those schools, one in Minnesota and one in Washington. Their applications were put on hold due to COVID. I'm not sure if Brett talked about that. So 2 other schools have submitted applications. Another school in Vermont was prepared to submit, and I think that there's another school in Minnesota that is preparing to submit. So several in the pipeline to move along the process. The CODA issue and sort of the hold that's been put on all dental accreditation program, or accrediting all dental programs, no matter what they are, is a complication and difficulty that we're going to have to figure out how to get around. I think in Minnesota, the way they structured that bill, they can go to the dental board in Minnesota to get initial approval or something. I mean, I think the way, and again, they drafted that legislation prior to the CODA standard, so I think they had some sort of caveats at that time that are not usually standard in legislation at this point.
Okay, thank you for that. And another question, I think it was on your slide, Brett, and I know this can kind of be a little complicated, but I think on your slide you had, in reference to Michigan, saying that there was a clean bill passed in Michigan. Without getting too much into kind of like the policy aspect, what do you mean exactly by a clean bill?
Sure. So by that, I mean a bill where politics has interfered as little as possible. And where, so Alaska was sort of the, well, not sort of, Alaska was the first place in America where dental therapy was practiced. And so the ability of replicating Alaska in other states. And Michigan was really the first state that passed dental therapy that just said not completely, but 99% said dental therapy as we see in Alaska is what we want to see in Michigan. And as Thera mentioned, their program is a 2-year, or it's a 3 academic year, 2 calendar years. So that's the distinction program. And so that is what we also see in Michigan. There are some states that have required dental therapists to either have a bachelor's degree, which makes, American Indians and Alaska Natives, compared to other demographic groups, have very low college graduation rates or even college attendance rates, for reasons that I could get into here, but I suspect most of us would already be pretty cognizant of. And so having that bachelor's degree requirement in statute means that suddenly dental therapy, remember in Alaska, 3 in every 4 come from their home communities. That's not going to be realistic for the tribes that are in those states. And another requirement might be, having a dual degree with a hygienist, which again, not 100% deal breaker, but when we talk about dental hygiene, we suddenly go from a pool in Alaska that's 90% native to a pool that's 90% white. And that can make cultural competence and building rapport with the tribal patient, it's an added barrier. And I'll just say, very tactfully. In states that have those requirements that have been around for a long time, the model is not as successful in tribal communities as it is in Alaska. So that's what we like to see, is a clean bill where basically it gives tribes the ability to replicate the success we saw in Alaska.
I can add to that if there's another second. So that, you know, to dive a little bit deeper in some of that, what we've found in one of the states that has the requirement for the dually trained provider, that educational institution was actually planning on doing both, you know, the traditional dental therapist and then the advanced standing dental hygiene dental therapist, and then in the process of building their curriculum in order to get it approved by CODA, the dental hygiene program changed the sort of goalpost on what it is to train a dental hygiene dental hygienist. And so another piece of the complication around sort of like layering on some of this stuff in statute is educational institutions already have their own process to get their curriculum approved. Then the profession itself has its own requirements. So you kind of have, like, you know, these requirements over requirements. When you then put it in statute, it's ending up to be a very complicated process for schools to sort of work this out. Again, they were just about to apply for CODA, and then the dental hygiene program which changed, which means the portion of their dental therapy curriculum had to change. And so, you know, it doesn't, from our perspective, the clean policy, if you will, it doesn't matter how you implement on your state. Keep your policy clean so you don't have to deal with those issues. If your educational program wants to stack those degrees, have it, you know, that's the educational program's right and should be, and the local community, if that's what you need, that's great. But when you put it in statute, it ends up to be a real problem when doing this. The other thing that we're sort of, as long as folks are sort of paying attention to the policy portion, make sure there's reciprocity. It takes a while. Don't require Oklahoma to have its own educational institution. Like, you know, be able to bring providers in, and that gives you, you know, the ability to get providers right away. It can take quite a while to build that program, and then you have things like this where COVID hit. That's a completely unlikely circumstance, but all of those programs are getting delayed, and it's just a number of complications. So make sure you have that reciprocity language so you guys can get dental therapists in there and aren't solely focused on making sure that you have programs. You know, another example is there was a tribal college in one of our states that doesn't have a dental hygiene program. And so for them, they really wanted to lead with a dental therapy program, but now they would have to build a dental hygiene program and a dental therapy program in order to have the program. So I think there's just a bunch of unintended consequences with some of the sort of complicated language. And this is a very small example of some of the complicated language that's getting thrown into bills. So you will be far better off with your sort of implementation efforts if it's just clean. And then however you guys implement is however you implement.
Thank you both for that clarification. Me being a novice at best at the language and all of that kind of vernacular, thank you for explaining that. I wanted just to read the chat box really quick while I'm after we finished up that question. I just wanted to clarify up here, let's see. Christopher Bailey said, now the proud tribe of Choctaws are beginning a focus into education and outreach, and I'm assuming that's dental therapy. If you want to clarify that, that would be fantastic. I know that was kind of a little bit earlier. Also, Dr. Lozon said, please find the last 10 years of oral health surveys at ihs.gov/DOH. The Division of Oral Health. They do have those surveys, all of those survey briefs available on the website. Thank you so much for that. Let's see. Christopher Bailey also said, please send me information on the doctor. And then also Lexus Williams says, please send me information. So if you guys could clarify exactly what information you guys were referring to. We'll make sure we'll get that facilitated and get what you are requesting to you at those email addresses that you sent there. Maybe that was specifically to Brett.
This is Chris Bailey. What we're doing is we do have a dental therapist. She's trained in preventative, and so she's doing some community outreach. We're starting to work with community nursing. We're trying to blanket Choctaw Nation to stem the tide of early childhood caries. I'm interested in the dental therapist program, so I'd like information on that particularly.
Okay, thank you. Thank you, Dr. Bailey. And you're from Choctaw Nation?
Yes.
Okay, awesome. We can get that information to you. Thank you so much for that. Also, let's see. Okay, Lori Humphrey said, can non-native hygienists attend a tribal college for dental therapy? And Brett answered that. So non-natives can and do attend the Alaska program, and other tribal programs across the country are still in the planning stages. And then from Bonnie Flanagan, Athens Dental Hygiene Association has been pursuing research to initiate a hygiene-based dental therapist in Oklahoma for over a year. State survey of hygienists has been completed with high acceptance, and we have temporarily because of pandemic and new lobbyists. Oh, okay, she said the Oklahoma Dental Hygienists Association. Thank you for that, Bonnie. Okay, so that's all I have in the chat box. I'm just going to give it just a few more minutes before we wrap up to see if there are any other questions.
And we do see that in several other states. The pandemic has really slowed, if the state legislature is still considering the legislation, that's kind of ground to a standstill, which is very frustrating, but kind of understandable. And then in states that have already passed bills but are implementing, we see that the pandemic has really slowed the state's ability to either develop rules or promulgate the rules. Which is frustrating, but we understand they're doing the best they can, and we're hoping to make as much progress as we can given the circumstances. But yeah, we do have several places and communities that we're looking at in 2021 for both the advocacy perspective and the implementation perspective.
Okay, anyone else want to unmute or put a question in the chat box?
Julie?
Yes, hi Bonnie.
Hi, I was playing with my phone, I'm sorry. I didn't know, when I asked my question, I didn't know if we pursue a hygiene-based dental therapist in Oklahoma, will that interfere with the tribal course at all? Will we be competing, or will they be totally separate?
Thanks, Bonnie, for that question. Thera or Brett?
Do you want me to go first, Thera, or you?
Well, I can. What I can do is say in theory that it does. We have not seen it. We haven't seen a place where it hasn't interfered or been complicated. And I think that there was a short window, and kind of what's going on with dental therapy is bills are passing and folks are sort of doing this work at the same time that states are implementing. And so there's a couple things that happen when one or the other moves forward with and it's done in isolation or seen as a separate track from the other, and that is it's seen as activity and action, and the other either tribal effort or statewide effort falls behind. What's also true, which we've found, is that if you separate them out, so some states have done, okay, well, for non-tribal communities we're going to do this, and for tribal communities we're going to do this, and that's an arbitrary and artificial barrier in the way communities live together, and it's actually ended up to be problematic as well. So I would say in general, passing legislation or focusing on everybody who's in support of dental therapy working together and going for sort of just CODA accredited allows you to do do whatever program you would like and have a dental hygiene, dental therapist provider without mucking up or disrupting other efforts. People have tried to slice and dice the bill in different ways. And the fact is, when that happens, it ends up being exclusive or problematic for other communities. So, we would recommend that, code accreditation allows you to implement in that way, however you want to do it. And you can, in putting it in statute, and that actually works for dental hygienists too. When we've done our work in communities, when you start sort of, determining what level of dental hygienist can be, it is acknowledged as the provider. Not all dental hygienists across the state, fall within that category, and then therefore either have to go back to school and get the full training or not. So, in general, we would say keep it cleaner and save yourself a lot of headaches. But that's been our experience. I don't know, Brett, if you have other thoughts or reactions in the work that you've done.
The only thing I will add to that is we saw in New Mexico. Utilized kind of a two-tiered system. So essentially, if you want to get a license from the state of New Mexico to practice, anywhere within New Mexico, you have to have a hygiene degree. To practice within the tribal health system, so for one of the Pueblos or at an IHS facility, you can just follow the Alaska standards. And the thing that is complicating that is, one, it's another layer, right? So it's the state now has to draft two sets of rules. The education institutions need to figure out how to build out a program, either one program that can meet both needs, or do they do two separate programs? So it has a few unforeseen consequences, or unintended consequences, I should say. And then there's also the issue of portability. If I work for the tribal health system for 5 years, and then my spouse moves away from a tribal community, and now I need to work in a non-tribal setting, suddenly I have a whole nother set of restrictions and requirements that I have to meet. So yeah, I think putting something like that in statute is something that we have to be careful of, just because we want to make sure that those unintended consequences don't hinder any potential dental therapists from working in a place where they're sorely needed, honestly.
Thank you.
Okay, and we have I think we have time for one more question. Angela Craig put in the chat, I believe that a board exam by CRDTS has been established for the dental therapist. Do you know anything about that?
So you look at me, Brett. This has come up a few times. Let me ask. I'll have to go back to Laura, who was supposed to be your presenter today. She probably knows this, and/or the status of it. I know that this has been talked about quite a bit, and I just don't know where it's at right now. So we'll have to get back to you. I don't know, Brett, if you have other information.
I do not. I don't have the latest. But again, with the pandemic, anything that was in development, we if it was going to take 1 month, okay, now it'll take 4 or 5 months. So it might be a little bit delayed. But yeah, we'll have to look into that and get back to you. And Angela, if you send me your email, I'm happy to follow up with you. Unless I think you might have already. Yes, I have your email. So I'll look into this and follow up with you.
Thank you for that question, Angela. Okay, and last question before we kind of do our wrap up and information to get the CE. I wanted to ask one question. This is really to the attendees and those here kind of in Oklahoma. With CHAP expansion into the lower 48 that Brett was kind of talking about earlier, is there any, and with the DHAT being, kind of aside from that and a state issue, is there any advocacy happening right now in Oklahoma that in pursuance of dental therapy? Can anyone speak to that?
Julie, this is Bonnie. Are you asking about advocacy, meaning the legislature?
Yeah, and specifically in regards to those that are involved or familiar with the community health aid program, because dental health aid therapy is part of that program, but it has to be authorized by the state as we've kind of established here. So I was wondering if anyone kind of affiliated with CHAP or working closely with CHAP knows if the dental health aid therapy or dental therapy is being advocated or pushed in Oklahoma.
Not to my knowledge, only what our association was doing, just working towards it. And then we've tabled it. We did our survey of hygienists, and then with the pandemic and a new lobbyist, we tabled it. So we're not working on it now.
Can you hear
Anybody
me?
else? Thank you, Bonnie.
Can you hear me?
Oh, yes. Hi, Dr. Smith.
Hey, so absolutely, there has been some tribal engagement with the Oklahoma Dental Association. They have been talking about it. I believe that the Cherokee Nation was one of the big drivers along with the Chickasaw Nation. They haven't gotten anywhere with it, but the federal side has not been engaged in those talks, just from the sheer fact that it's, obviously tribal driven and all that. So I know Dr. Lozon's on here. The biggest problem that we had originally was getting position descriptions and all that kind of stuff laid out so that we could get it to move forward. So the State Practice Act right now does not allow it. And so that's what has been in discussion with, how they're going to modify it and all that. So as of right now, nothing has happened with that. But I know that two of the larger tribes have been in discussion with the state about that.
Okay, thank you so much, Dr. Smith. Appreciate that update. Okay, all right. So let's wrap this up. I appreciate everyone's slide attention, and thank you again to our speakers. So this is kind of a call to action page. So if you're not already a Native Oral Health Network member, please do so. Kind of join us, help us further inform our work. Alex is going to put the link that's here embedded in the PowerPoint. It's going to put that in the chat box for you to join us. Also visit our webpage, the Native Oral Health Network's webpage. There you can find the on-demand webinar, the Tribal Oral Health Services during COVID-19, that talks a lot about teledentistry implementation with one of our tribes. I believe it's with Chickasaw. We partnered with the National Indian Health Board on this webinar as well. Also talks about some of the process and things that are that some other tribes are doing and implementing during COVID. So be sure to check that out. We'll also have our oral health data resource guide where you'll find all the information listed there available. If you would like that in print, send me an email and I can absolutely print that for you and mail that to you if you do not want that via the web. Okay, so thank you so much for your time and attention. Again, I'm sorry, I think we're actually 1 or 2 minutes late, so sorry to go over, but to get your 1.5 hours of CDE credit, you follow the link to this evaluation, which evaluations are completely anonymous. Alex will also put that into the chat box. Click on that link, complete the evaluation, and you will be automatically redirected to the course attendance verification. Also on that forum, you'll find, if you are a tribe or a tribal serving organization, you will find instructions to access that information in the dental portal, in the IHS dental portal to obtain your CE credit. And it's 3 o'clock and my little one's back just on time. If you have any questions about CE or anything, please send me an email and I'll be happy to facilitate any questions. So again, thank you so much. I appreciate it. Thank you to our speakers. You guys have a great rest of the day and weekend.
Lori,
yes.
sorry, Lori, the next course, the next webinar will be December 3rd, and then the one after that will be January 14th. I just wanted to put that out there.
Okay, thanks so much, Alex. Appreciate that. If you sign up for kind of our listserv to be a Native Oral Health Network member, you'll get all of those email. Thank you. You'll get all of those email notifications, reminders. So thank you guys so much. Appreciate it. Have a good rest of the day.
Thank you, everyone.